Thank you for inviting me. Thank you for the introduction, and I'm so happy that everybody's here. And it's also a pleasure to share with other big people who are doing global mental health. So it's an honor just to be speaking. Hopefully, I'll say something of value. So this is the picture that many of us have when we go to a beautiful place. We just go to do tourism. And even though, as Kathy say, I'm Brazilian, my mother made a huge mistake, even though she made very few mistakes, of not teaching us Portuguese. So in my second visit to Brazil, which was totally to enjoy these, I discovered that there's another world beyond the beauty of Rio de Janeiro and the beauty of the people of Brazil. So I'll tell you my story. So I stuck to the title of the panel, and I'm going to tell you my story that ends up with Maria and I then coming up with a T32 Global Mental Health Fellowship that we take postdoc fellows, and we're always happy to hear from you if you're interested in a global mental health career. But I'm not going to talk about that today. So when we talk about culture, it influences everything. So I'm not going to go through every one of them, and culture influences every part of health and mental health that we do. And throughout all of these systems, contexts, individual patient, supervision, because I've had supervisors that know much more about Latinos than I do, and I'm a Latino. So there's always a barrier or a facilitator of what is involved in culture and all those different aspects of health and mental health. And it can lead absolutely to miscommunications. And I'm not going to give you all the funny jokes that I can give you about how people have misunderstood things that I say or the things that you tell them, believing that you're speaking the same language. And the problem is that it's not just funny, it's actually quite problematic because we can be doing completely different things, as Roberto very clearly stated before. And when we look at, as David very well mentioned about the issues of policies around the world, you need to ask yourself when you see, and I don't know if I have a pointer, but if you see that you have different manifestations of policy acquisition in mental health and delivery, even though some countries may have strategies, they have not become policies. And the question that at times we need to ask, it's the issue about culture and context. Or what are the issues that can interfere with the ability of these policies to be there. And if you look at the data that WHO has put together to think of disorders all over the world, I am moving to Nigeria, I don't know about you, and if you want to practice, you should move to the States so you can have more patients. So it's sort of like a little bit strange that we have such a variance, and the question is it culture? Is it poor science? And I'm not saying that the WHO does poor science, but we need to think of how we're assessing these things, and definitely the context. And Annika Sweetland, which is my first fellow, our first fellow in our fellowship, came up with this beautiful slide when she was talking about work that she was been doing in sub-Saharan Africa, which talks about the approaches to assessing mental health across cultures. And we would love to have the side of being a quantitative universalist measure, yet at the same time, we need to understand that there's context and culture, but we cannot just move all the way to the right, and we need to find a way to do mixed methods to understand how we get there. And some of the previous panelists have talked about that. So my work began in Brazil in HIV, and HIV is the disease that made task shifting and task sharing happening, and definitely understanding that we need to think of others and not just health providers as the ones who are going to be doing the work. And so I went there to give a talk. They invited me to a meeting after the talk, and I met with nurses, social workers, and an occupational therapist, and we decided to apply to get funding to bring HIV prevention interventions for psychiatric patients that had been done in the United States to Brazil. And we got the grant in the first time that we applied. So somebody at NIMH thought these people are interested in doing implementation research, and what we did is we worked in the settings. And it was an incredible opportunity. And as you think of psychiatric patients and sex and HIV, the reality is that they're all over the place. They can be having sex with the same partner, with the same gender, they can be sex workers, they can be injecting drug users, they can be homosexual, heterosexual, they can be pregnant women, et cetera, et cetera. They're among the population that it's infected. And actually, so you know, psychiatric patients, most of the places where we have done studies have shown that they are higher risk and are more infected with HIV than the rest of the population. So that's what they thought that it was important what we were doing. And when we were talking about bringing these interventions to Brazil, This is what everybody was saying, which is some of what we're saying today. You need to adapt it. So there's brilliant work on cultural adaptations in suggesting that these things need to be taken into consideration. However, when we were looking for how to do it, there was nothing in the literature, and there was no guidance in how to do that. So we decided that we would come up with a way of doing that, and we published way back in 2007, although this was work that we did in 2002, but you know how it is to publish something. It takes a little bit of time. And the idea, and it's partially, David, with what you talked about, the 4 A's, is how do you make sure that you keep fidelity with the evidence base that it's happening, that has been done before? How do you make sure that it fits in the context that you're trying to intervene with your intervention? And how you balance the two of them, and then how you pilot, test, and refine and move it forward. So this is the model that we put together for the work that we did, and it was beautiful because I got to meet everybody in a hospital, even the guy who makes sure that he sees everything that happens in the institution because he's in a cantina, he's in the place where everybody eats and has coffee, yet he knows everybody and what they're doing among them because he watches them. So we did beautiful formative work, and we followed this process where, number one, we needed to be trained in their work, in their activities, and we needed to train them in some things that they had no idea how to do. We identified efficacious interventions that we would be using. We identified common content areas and messages that needed to be delivered in an intervention. So this was fidelity. Then in number 2, we worked for fit, and I'm going to speak a little bit more about that, where we definitely needed to create a culturally informed and cohesive research team to work in what we would be doing to move forward, foster local collaboration and acceptability. And what we did is that we included all the parties that are involved in government or would be involved in government to make sure that in the next phase, if there would be a switch of parties, we would continue to be able to work with them. And definitely, Elisa, oh my God, it's already 7 minutes now. Good. And the idea then was to balance those two. And the balancing was not just like, well, let's think together what would work. It was always trying to balance the fit and the fidelity at the same time. And then move on to do pilot testing and refining, final intervention, efficacy versus effectiveness testing, which I'm not going to talk about, but it's something that is the area of research where we need to think about. So when is enough to do efficacy or move on to effectiveness? But that's a long, and I don't have the minute and a half that I need to talk about that, and definitely scale up and dissemination. Optimizing fit. There are very important principles: language, cultural context, culturally specific messages, creating a culture-informed and cohesive research team, foster local collaboration, identify the cultural principles, and eliciting the needs of the population, and include everybody and their siblings in all of that. And the balancing requires participation of key stakeholders. And you have over there the list of everybody that we included, and we basically added and added. We invited people who were interested. We trained them in what we knew, and we asked them to train us in what they knew, because what makes me think that I know more than anybody? Building consensus and completing adaptation through experiential workshops. So we also got to do activities in front of us and watch ourselves, ask the questions and see, does that really work, Roberto, or should we do it in a different way? And the building consensus was some workshops where we retained components of the efficacious interventions. And everything was, is it Brazilian? We asked over and over again, but anybody who would speak would have to say, culturally, we have this, and there would be the work of the ethnography of the formative work, and this is the evidence. So anybody who would comment on something would have to make sure that we do both things at the same time, because the structure was, we need to respect both things. And we came up with an intervention, and this is the beautiful people that includes everybody, every interdisciplinary option that you can think about, and I'm not going to mention them. And then, in collaboration with, one of my other beautiful partners in life, besides Maria Oquendo, is Cristiane Duarte. We're now working with adolescents, and as you can see, the influence of sociocultural context and sociostructural context as very, very important parts when you, for example, talking about youth. This is an HIV prevention intervention for adolescents with mental health disorders. So, capacity building. In all these names that you see here, there are 13 researchers. The others were people that we trained. We did issues in recruitment, in facilitation, in assessment. 2 of them have moved on to do PhDs. And some of them leave us and brain drainage from the study and the team, but at the same time, it's very wonderful to see them developing other. And they did beautiful work, and trying to include everything, this is what I have to say. Thank you so much.